the morning because we have later the lecture from Professor Dufo, and Eduardo knows him very well. Eduardo Ribas is a neurosurgeon from Brazil. He's going to talk us for us about microsurgical anatomy of the insula. He was also, as many others, the fellow, one of the fellows, one of the last fellows of Dr. Roten, and he was also a fellow with Dr. Dufault regarding the experience of him with tumors. So, Eduardo, please take your time and show us your lecture. Thank you very much for the acceptance.
Hi. Thank you. Thank you. First of all, I want to say thank you for the organizers. It's great to see everybody together. When you press and see all the faces together, it seems like we are in a congress. It's good to see friends and teachers and people that I learned so much from. And every time I see your lectures over and over again, I'm always learning. So it's a pleasure for me as a student to see your lectures again. So I'll try to keep short, and it's good to be the last one because then I can refer to the other lectures that were great. Congratulations, all the other speakers, and thank you for the wonderful lectures. So today I'm going to talk the microsurgical anatomy of the central core, also of the insula. These are different terms. I prefer the term central core. But let's talk about it. So deep inside the sylvian fissure, we'll find the cortical surface of the insula. And the cortical surface of the insula is separated from the rest of the brain by a circular sulcus, is the peri-insular sulcus, that can be also subdivided into one anterior, one superior, and one inferior limiting sulcus of the insula. It's interesting that the insula is the most lateral aspect of a very different compartment of the brain. While all the rest of the brain is made from gray matter on its surface and white matter on its inside, this part of the brain is different. It has collections of gray matter that appear to be encapsulated by white matter. And traditionally, this region is studied by this axial cut that we can see the disposition of these structures that appear to be in layers. So we will see them as layers coming from outside in, from lateral to medial. So the first layer is the insular cortex, it's gray matter. Then just deep to this layer, just medial to this layer, we'll have the extreme capsule. The extreme capsule is made by short association fibers that are connecting together the insular sulci and are also continuing towards the opercula. Then a little bit more medial, we have the claustrum. The claustrum has a different circuitry from the other basal ganglia. So some authors will not refer as the claustrum as basal ganglia because it has a different circuitry. There's a very nice article about the claustrum from Fernandez Miranda. Then medial to the claustrum, we have the external capsule of the lentiform nucleus. The lentiform nucleus will have one external capsule and one internal capsule. The external capsule is lateral and the internal capsule is medial. The lentiform nucleus is made by two nuclei. So the putamen, it's bigger and more lateral, and the globus pallidus, it's on its corner, more medial. Then medial to the lentiform on this anterior aspect, we have the anterior limb of the internal capsule, separating the lentiform nucleus from the head of the caudate nucleus. Remember that the caudate nucleus is a C-shaped nucleus that's wrapping the thalamus. So the thalamus will be medial to the posterior limb of the internal capsule. The internal capsule has 5 segments, right? Anterior limb, genu, posterior limb, then heterolenticular segment, and sublenticular segment will be inferior to the lentiform nucleus. So the central core will be all these structures put together. This is a morphological concept because we are putting together a lot of different structures that has a lot of different origins together. So some people will not see it embryologically as an accepted term, but morphologically and architecturally, it seems to be a well-defined region. We are putting together neocortex, white matter, basal ganglia, diencephalon, the thalamus inside the diencephalon. So we're putting a lot of different structures together, but they appear to be architecturally together. It's interesting that each cerebral hemisphere will harbor on its morphological center one central core. And these capsules, white matter capsules inside the central core, they are spread by these collections of gray matter. But when they continue towards the other cerebral lobes, they will merge together on this superior aspect of the central core, posterior aspect, and inferior aspect. They will converge together, and they cannot be seen separately, especially in surgery when you don't have a special preparation to individualize these white matter tracks. So you just see white matter, but they are all them three are together here: extreme, external, and internal capsule. So if you see, there is you can understand the architecture of the brain by seeing the central core on its inside, its morphological center, and then putting on top of it the other cerebral lobes. So anteriorly, you see the frontal lobe, superiorly, you see the parietal lobe, posteriorly, the occipital lobe, and inferiorly, the temporal lobe. And the ventricle cavity, the lateral ventricular cavity, will be wrapping this central core in a C-shaped aspect as well. This white matter capsule, they continue to the other lobes. This is the internal capsule. These are projection fibers with this radial disposition. And this is a deep cut made at the insular limiting sulci. And you can see how it's easy to reach the lateral ventricular cavity and detach the central core from the rest of the brain. See how this region can be easily detached from the rest of the brain. The limbic lobe will be wrapping around the central core, particularly the thalamus, and this is why it's called limbic. Limbic means wrapping around. So the limbic lobe, the limbic system, will have basically two Cs. It has an outer cortical C made by the parahippocampal gyrus that continues with the cingulate gyrus. This is the outer cortical C. And then, as Professor Wen said, inside the uncus, we'll have the amygdala, the hippocampus, and then the hippocampus continues with the fornix that will end at the mammillary body. This is the inner subcortical C. So it has these two C's wrapping around the thalamus, but also the central core. This is a superficial view. We have here the central core. This bump here, more medial, is the thalamus. Someone have a question? Sorry. So this bump here, more medially, is the thalamus. And here we are detaching the inner C from the thalamus. We're just enlarging the choroidal fissure. The choroidal fissure is it can be used as a surgical route here to the roof of the third ventricle, but here we are just seeing how these structures, they are just put together, but they are not connected together. The fornix is just wrapping the thalamus, but they are anatomically separated by the choroidal fissure. So if we open the choroidal fissure superiorly, we'll reach the roof of the third ventricle. If we open the choroidal fissure posteriorly, we'll reach the pineal region. And if we open the choroidal fissure inferiorly at the temporal horn, we'll reach the ambient cistern. So seeing how this, the hippocampal formation made by the hippocampus with the fornix, this can be really easily detached from the central core, from the thalamus particularly. Just as Professor Wen said, anteriorly and superiorly to the head of the hippocampus, we'll find the amygdala. And the amygdala cannot be easily detached from the central core. The amygdala actually continues with the globus pallidus. They don't have a natural clear cut between them. we'll say this posteriorly how to cut them. So here is the limbic system. This is the outer C, cortical C. And if we turn these structures in seen on the inside, we see inside the cingulate gyrus the cingulum. This is a white matter bundle, the cingulum inside the cingulate gyrus. And then inside the parahippocampal gyrus, we'll find the amygdala, the hippocampus, and the fornix. This hole here, it is the place of the thalamus. So it is embraced by this C-shaped formed by the fornix. So amygdala anteriorly, then hippocampus and fornix. We can see here that the amygdala and the head of the hippocampus, they are already separated between them. It's the uncal recess between them. And just to see here how the amygdala is anteriorly and superiorly to the head of the hippocampus. The hippocampus has a head, a body, and a tail, and its white matter will collect and form the fornix. The thalamus was supposed to be here, inside here, and resting on this surface, this upper flat surface of the parahippocampal gyrus called the subiculum. It's where the thalamus is resting. On the superior view, we can see here, the thalamus was here. It was resting here all over the subiculum. And if we see the space between the subiculum and the fornix, we see this more vertical gyri. These are the dentate gyri. Here is another preparation. We opened the sylvian fissure, exposed the insular cortical surface, and made this deep cut from the insular sulcus, from the insular limiting sulci towards the lateral ventricle, and we can see how we can really detach this central core from the rest of the brain. If we continue even further medially and open the choroidal fissure, then we can see how the limbic system can also be detached from the central core, but not the most temporomedial structures, particularly the amygdala. The amygdala will continue with the globus pallidus. And how will we detach the amygdala from the globus pallidus and not get inside? Professor Wen, I studied with Professor Wen, always my teacher at the University of Sao Paulo, and he taught me that if we connect the inferior choroidal point, that's where the anterior choroidal point is getting inside the lateral ventricle, the temporal horn of the lateral ventricle. If you connect the inferior choroidal point to the ICA bifurcation and draw a line here that he calls the carotido-choroidal line, and we just follow laterally to this line and make a cut here, we'll make this cut lateral to the anterior choroidal artery, and we will detach the amygdala from the central core, from the globus pallidus particularly. Other surgeons will look more superiorly towards the optic tract and see the optic tract as a reference. It can also be done, but maybe it's easy to see those points and connect those points. Each cerebral hemisphere has a central core on its morphological center, and they both continue with the mesencephalon. I always see this picture and I remember a dragon with two heads. So it has the body of the dragon, but it has one head inside one cerebral hemisphere. There is not a clear division between what is central core and what's brainstem, particularly what's diencephalon and mesencephalon. What will be the distinction between diencephalon and mesencephalon? Most anatomists will look for the optic tract as well, and the inferior aspect of the optic tract will separate what's inferiorly the mesencephalon from what's superiorly the diencephalon. Professor Kadri showed a lot of white matter dissection, and I'm just gonna reveal, but now in the light of talking about the central core, the insular lobe. So here's the first step of the lateral white matter dissection. We can see the first subcortical layers. It's made from the U fibers, the short association fibers. They are just beneath the cortical surface, and it's connecting the gyri that are close together between them. If we continue the dissection more deeply, we'll see in this perisylvian region, we can see the superior longitudinal fascicle. This is the concept that will harbor inside the arcade fascicle. I'm just showing this picture to show that this phonological loop that is meant for selecting phonemes in a word, it's a language stream. It is not inside the central core, so it's outside the central core. It's a perisylvian fiber tract. It's not inside here, and we cannot see them if we are exploring the central core. If we see the insula, Dr. Matthias showed us that it has two compartments, one anterior and one posterior. The anterior is made by short insular gyri that will converge towards an apex, and the posterior compartment is made by long insular gyri that will not reach the apex, and between both compartments we have the insular central sulcus. Anteriorly we have the lumen insula. Just to review here, anterior limiting sulcus, superior limiting sulcus, and inferior limiting sulcus, separating the insular surface from the rest of the brain. If we scratch, if we decorticate the insular surface, we'll see the extreme capsule. The extreme capsule is the first subcortical layer deep inside the insula. It's made also by short association fibers, putting together the insular gyri between them. If we continue more medially, more deeply, we'll see the claustrum. The claustrum is made by two compartments, a dorsal claustrum more organized into a sheet of gray matter, and the ventral claustrum is just a brownish appearance of these fiber tracts here. But it's, when we say claustrum, we are really more talking about the dorsal claustrum. And from the claustrum will arise the claustrocortical fibers. They will spread almost towards all the cerebral cortex. It has a very big spread towards all the insular, all the cerebral hemisphere. These are the most posterior fibers here. Anterior to the claustrocortical fibers, we see the IFOF, inferior frontal occipital fascicle. This is also called the occipital frontal fascicle. Professor Kadi preferred this name, as Professor Yashar, because it is not a superior frontal occipital fascicle. So if it's not a superior, why is there one inferior? But the literature is a little bit confusing, and some people will prefer to call these fibers the IFOF. I personally, I like IFOF, but everybody's free to choose their words. And this is also a language stream. I know we'll have Professor Dufo lecture in the next hour, and he likes a lot to talk about the IFOF. The IFOF, if stimulated during surgery at the dominant hemisphere, the left hemisphere, will make the patient have semantic paraphasias. So he will change some words, maintaining the semantic category. So this is also one language stream. It's a little bit controversial, but Professor Dufo likes this concept. Some people will agree or not, but it's something that is on the literature right now, and so it's the IFOF, a new, I think, rediscovered ventral stream, ventral language stream, so passing in the insula. And the uncinate fascicle. The uncinate fascicle is right posterior to the lumen insula. The uncinate fascicle will connect together the frontal orbital region to the temporal pole, and it will be the first fibers here. If we remove the claustrocortical fibers, we see the putamen here. The putamen here is more dark. This specimen was frozen, so that's why it's a little bit more dark. We see the structures here, the IFOF and uncinate fascicle. If we remove the IFOF, you see the anterior commissural fibers coming on a different direction. So if it's commissural fibers, they are connecting both hemispheres, so it has this other orientation from one hemisphere to the other. The putamen is superior to the anterior commissure. If we remove the putamen, we see the globus pallidus, and we see beautifully here how the anterior commissure is passing on this ventral pole of the globus pallidus at a channel called the graciole channel, So it's a channel where the more compact fibers of the anterior column is passing here towards the temporal lobe. If we remove the globus pallidus, now we have removed all the lentiform nucleus, and we'll see medially what fibers are medially to the lentiform nucleus. Those are the fibers of the internal capsule. So that's why it has this radial disposition, because those are projection fibers that are mainly going to the cerebral peduncle. So this is why it has this radial disposition, because they are merging together and going to the cerebral peduncle at the mesencephalon. Now bring attention to this region here. This gray matter here belonged to the putamen. But medially to this gray matter here, will not find internal capsule fibers. And this gray matter here will merge medially with the gray matter of the head of the caudate that is positioned medially to the internal capsule. So because medially to this region we don't have projection fibers, internal capsule fibers, this gray matter will merge, and this will form a nucleus called the accumbens, or the ventral striatum. The ventral striatum because it's ventral disposition. This is the striatum, right? The putamen and the caudate nucleus medially. This is the ventral striatum or the accumbens. So here we have removed the putamen, and we see here how there are not internal capsule fibers here, and this is why the gray matter of the putamen will merge with the gray matter of the head of the caudate that's medially. Okay, and now this is a more enlarged view how the internal capsule fibers inside the central core is called internal capsule, but outside the central core it changed its names to corona radiata. So these are all projection fibers, but outside the central core it's called corona radiata. And beautifully here we see the Myers loop. These are geniculocalcarine fibers. They are coming from the lateral geniculate body to the calcarine fissure. So this is optic radiation, and here it's a loop of this some of these fibers inside the temporal lobe, and this is why surgeries addressed to the temporal lobe can give patients optic disturbances, optic functional disabilities because of harming those fibers here. Okay, now we are more deeply inside the geniculocalcarine fibers when we see some fibers that have a more vertical disposition. Those fibers are arising from the corpus callosum. These are callosal fibers, and they are going towards the base of the temporal lobe. These fibers are the tapetal fibers. It's the tapetum. And what I want to show here is that the tapetum is not inside the central core. So the tapetum are fibers outside the central core. They can progress even further anteriorly inside the temporal lobe, but not inside the central core. Since we have removed a lot of white matters, we can see here from transparency almost the caudate nucleus with a head, a body, and a tail, and the tail continuing with the amygdala. Now we open the temporal horn, we see the hippocampus here, and how the hippocampus and the hippocampal formation and the opening of the choroidal fissure can separate these structures, the central core from the choroidal, from the limbic system. Now the vascularization. The central core has two types of vascularization, two patterns of vascularization. It has these traditional patterns. All the brain is basically made of these traditional patterns. So it has large arteries on its surface, and from these large arteries, some small branches will arise and supply the gray matter. This is the cortical surface from all the brain. So this is the traditional pattern. But the central core will have perforators. So we have different kind of vascularization as well. So these perforators, it will arise from the proximal segments of the polygon of Willis and will perforate the anterior and the posterior perforated substance and supply the central core. So the anterior perforated substance here will be perforated by the lenticulate astrate arteries that are arising from the ICA bifurcation, proximal segment of M1, A1, and it will supply the lentiform nucleus, the striatum, and the internal capsule. Opposed to the posterior perforated substance that it's perforated by the thalamo-perforated arteries. Those arteries are arising from the basilar bifurcation, proximal segments of P1 from both sides, and it will supply mainly the thalamus. So this is preparation where we have removed the central core from our side, and what we are seeing here is the lenticular astrate arteries here. They will reach the anterior part of the central core, so mainly the caudate nucleus, the lentiform, and the internal capsule. And here, posterior from the mammillary body, we'll have the posterior perforated substance, and it will be perforated by the thalamo perforated arteries and will supply the thalamus. We can see here this very elegant trajectory of the posterior medial choroidal artery. The posterior medial choroidal artery will arise from P1 or P2, and we will have a very elegant trajectory. It will first reach the crural cistern, then ambient cistern, then quadrigeminal cistern, pineal region, and then get inside the roof of the third ventricle, that's the velum interpositum, and supply the most medial and superior aspect of the thalamus. So it will supply the central core as well. And some people have some difficulty in understanding the trajectory of this artery, but here is a nice picture of this trajectory. It's a very long and beautiful trajectory. Another dissection, so we are coming from lateral to medial, and what I want to show, these are the fibers, uncinate fascicle, IFOF, putamen, and globus pallidus, and this is a tip from surgery. So if you stimulate at the left side and you have cementic paraphasias, you will stop the removal, for example, of insular glioma at the depth of the IFOF, for example, because you have cementic paraphasias and you will see this as a functional boundary, you will not continue more medially. But imagine you are operating at the right side and you don't get cementic paraphasia and stimulate this patient. What is the next deep step that you're gonna see and stop your dissection to go more medially? You see the lenticular striate arteries. They are mainly medial to the external capsule. They are medial to the IFOF, and here they are supplying the putamen here. So here there are the lenticular striate arteries perforating the anterior perforated substance and continuing to the putamen. Here we are separating the putamen from the internal capsule. So these lenticular striate arteries, after supplying the putamen, they will continue more medially towards the internal capsule. And that's why if you harm one of those arteries, you will not just get a stroke from the putamen, but you will also get a stroke from the internal capsule, and probably you have a motor deficit as well. Here we are removing the putamen, and you can see how perforators is a nice name to those arteries because they're really perforating those structures. It's perforating anterior perforated substance, and then it's perforating the lentiform nucleus as well. Here the putamen being removed. We remove the putamen, we remove the globus pallidus, and here's a superior view. This is the internal capsule, and we are spreading the caudate nucleus from the internal capsule. And we can see that these fibers, after these arteries, after supplying the internal capsule, they will continue even more medially and then finally supply the caudate. They have a long trajectory. Here's an anterior view. We can see ICA bifurcation, A1 and M1. We can see the lenticular striate arteries. So they will perforate the anterior perforated substance, supply first the putamen that was removed here, continue more medially, supply the internal capsule, and then continue even more medially and supply the caudate nucleus. This is the traditional trajectory of those arteries. But one artery has a more direct trajectory. It will perforate the anterior perforated substance on its most medial aspect and continue directly towards the head of the caudate. This is the Heubner artery arising from A1 or A2, and it will perforate the most medial aspect of the anterior perforated substance and supply directly the head of the caudate. Here are just final pictures to show the anterior commissural fibers. This is the hemispheric extension, but it also has a ventral extension or olfactory extension, not so evolved, but it's small. And here is a superior view of the anterior perforated substance. So just superior from the anterior perforated substance, we'll have fibers that are arising from the amygdala and continue more medially. These are the ventral amygdalofugal fibers. And if we see them together, they form the ansa peduncularis. Ansa peduncularis because it's wrapping around the cerebral peduncle. And we can see a set of fiber pathways here from the amygdala to the septal nucleus, to the septal region. This is the diagonal band of Broca. Then posteriorly from the amygdala to the thalamus and hypothalamus and maybe mesencephalon as well. I made a research using the position of those fibers deep inside this region, and understanding the position of those fibers, we suggested a subdivision of this region into quadrants and proposed how to stimulate and how to understand each quadrant harbors each fibers, which quadrant is more eloquent, which fibers can be worked more freely. And if you look for our publication at the Journal of Neurosurgery, you can understand further these quadrants and how these can be anatomically understood this region. Okay, thank you for the invitation. I try to be short. I know it's a lot of information, and thank you.
Hello.
Hello, Alencastro. Hello.
Yes, Eduardo, thank you very much for this lecture. It was wonderful, as always. Thank you for this very complex area understanding. We could open for the panelists for questions. Does any of the panelists has any question for Dr. Ribas or Dr. Wen or for the other panelists, the presenters?
Alvaro, how are you?
Hello, how are you?
I'm fine. Thank you for
the
organizing. Yeah, it's
Excellent.
good to see everybody
Stefan
together. It's nice.
Excellent lecture, Eduardo.
Stefan is still there? Stefan?
Stefan, where is Stefan? I don't know. He's a few hours ahead of us, so it's Saturday.
I'm still there. Still not sleeping yet.
Okay.
Okay. There is
excellent presentation.
There are a lot of
really.
questions. There are a lot of questions about brain shifting.
No, I tried to answer them already on the questions area. Yeah, brain shift is a problem, of course. But honestly, we always try to cope with it if we use surface navigation. Yeah. So honestly, if you reconstruct your brain surface with vessels, yeah, you don't need navigation system. You print it out, for example, or you make a picture with your phone of the brain surface. You know where your tumor is underneath, and then you compare it after your craniotomy with the surface. You know, and if you compare the vessels and the gyri, sulci, you exactly know where you have to enter, and it doesn't matter if you have brain shift pushing that surface out or not. Yeah. So this is the first thing, I think. Yeah. This is how to overcome brain shift at the surface. So then until the bottom of the sulci, you are okay. You can rely on your anatomic knowledge and on your surface reconstruction. Then in the white matter, you're already quite deep. And the deeper you get, the smaller is your brain shift. You know, in the very depths of the brain, there is no brain shift. It's usually at the surface, isn't it? Yeah. But altogether, of course, direct subcortical stimulation of the white matter is always more reliable, much more reliable than relying on DTI tractography. However, DTI tractography shows you where the direction is to your tract. It shows you in which area you have to be careful. yeah, and where you have to be reluctant to remove too deep. Yeah. So honestly, in general, I don't feel that brain shift is a big problem.
Dr. Stefan, you were talking about brain shift, and you use a lot of stimulation. And so, do you, instead of to cope with the brain shift, do you like this rule of milliamps, and 1 milliamp is 1 millimeter from the motor fibers? How do you see this?
So we use this. We use this rule. Yeah, and we also have the experience that 10 milliamps corresponds to about 1 centimeter, 10 millimeters. However, if you get below 10 milliamps, if you get to 5 milliamps, it's getting dangerous. Yeah, because of course your bipolar is generating some depth destruction. Yeah, so below the surface. So we would never try to go below 6 milliamps. Yeah, to keep a safe distance to the tract. And that's usually possible. I showed this case with 1.5 milliamps, but if you see that, you're usually right on top of the tract, and in most cases you have created already some damage. So always try to stay above 5, 6, 7 milliamps. Yeah.
Yeah, remember that just for everybody, if you are stimulating at the central cord, there was my lecture. So before 6 millimeters, you will already have the lenticular right artery. So this it's safe maybe from other regions, but at the insula you might want to stop with maybe 1 centimeter or a little bit more than 6, but it's nice.
So Eduardo, I have to return the question. How do you know when you approach the putamen in an insular glioma? How do you know you have to stop, or how do you know there's still tumor left? Because in so many cases of insular gliomas, you leave some large area of tumor behind medially because you were not sure, is this already the first lenticular stride, first perforating arteries, and you should stop here, or is there still tumor left? So what's your experience on that?
Well, I personally have just a few experience with insular gliomas. They are rare, right? And at my university, I'm working more with benign tumors, and I'm personally not with the GBMs or low-grade tumors of this region. But I joined Professor Dufo for a while, and he's always claiming that you can see the putamen because a little bit more dark than the white matters. And if you pay a lot of attention, if you look for it, you have to look, you have to know what you're looking for, right? So if you pay attention, and maybe you see a little bit darker. At my pictures, the specimens were frozen, so the putamen in real life will not be so dark. It will be just a little bit darker and maybe more more consistent than the gray matter. It will not come with the suction so easily.
So I fully agree. The thing is that once you are at the putamen and you see the darker matter, the dark matter, gray matter again, it can be already very dangerous that you have cut some perforating arteries, which are very difficult to coagulate, as you know. And if you coagulate the wrong one, you may have caught an ischemic lesion of the corticospinal tract already, which happens. So what I like is the idea to use ultrasound Doppler of inside the insula area, inside the glioma, because there you can see the perforators. If you have a good one, you can really see it, and then you know how deep you can go. Yeah, that's a very nice.
It's nice. That's nice. Yeah.
Yesterday, Professor Mitchelberger gave us a very interesting lecture, and he was talking exactly about that: how to recognize when to stop the glioma and to identify the putamen. And he says for him today, the most true point to stop is when you see the first lenticular arteries, the lateral ones that pass through the putamen, and he pays attention quite well to that. Of course, monitoring, but that's the most important aspect for him to stop dissecting tumor for this region. And of course, as we all know, and more, we know we have the opportunity to operate the patient again. So when you are not really sure and you don't have any kind of intraoperative MRI, you can stop, check the MRI and go back, and you know exactly where you can go further, because I think it's also always better to stop before. I really don't have, and many patients, I explain to them that I have the chance of doing it in 2 surgeries instead of 1. So I think that's a very important thing, especially for beginners, for the youngers, is to know that it's not problem at all if you do it in 2 surgeries instead of 1.
Yeah, you're perfectly right. Probably it's not the right tumor for the beginner anyway.
Any of the panelists would like to
Dr.
make
Valerio
a
had
Valerio?
Alencastro. Dr. Valerio
Yes.
had 2 questions before.
Sure.
Go ahead, Valerio.
Yeah. Hi, Stefan. How are you? So,
Hello, hi.
so there are some new products from, I don't know if Medtronic use it, but I know the Brain Lab has it. That is a
Yeah,
virtual shift reality study that where you do a craniotomy, then CT and ultrasound, and you basically can identify the shift. I don't know, there's somebody's interfering over it. And you can identify the shift where the tumor move. And in that way, they have been with that algorithm able to resolve the small shift. I don't know if you have experience with that. I know there is a new product, and what was the advantage of that with respect to the DTI, to the tractography? So
no, I don't have experience with it. I've heard of it, and I know a group that does ultrasound on the surface and matches it to the images and does some like reconstruction, but reformation of the image. But I don't know. I have never heard that it's like on the market. Yeah, so you may know better. But again, if I use surface reconstruction and map my anatomy, you know, between the picture and the brain surface, I'm good at the surface. I don't care about brain shift. And in the depth, yeah, you have to rely on navigation, but the shift is much smaller in the depth, so it's usually not a problem.
And now in the era of COVID-19 and webinars all around the world, what do you think about navigation and virtual reality to present and discuss cases now? Instead of having just the webinar, now we will have our cameras here and we can see the tumor and the brain around it. Do you think that it's going to be just an educational tool, or you think that it's something that's going to help us in reality for any surgical procedures in the future?
So, you know, I'm very technologically oriented, and I like 3D and virtual reality and augmented reality stuff very much. But I always feel it must not take too much time. Yeah? If you have to put it together, it takes you hours to calculate 3D surface volumes, segment. I think then it's useless. We need fast solutions. Yeah, we have no time before surgery. Yeah, we want fast planning solutions. And I usually, with this augmented reality stuff, it takes a lot of preparation time, don't you think? So I think it's maybe not right there.
Correct. The only thing is the goal of all this is looking for safety and accuracy in our procedures to try to have a better result. Yeah, I believe, like you said, that we are not probably there yet, but it's an interest new change in technology that it can be useful for us. How much is going to be useful, I don't know. That's why I asked the question.
But you know, I think we have made some steps ahead. So nowadays, every neurosurgical planning software has the possibility to calculate a 3D brain surface very fast and very precise. Yeah, so you can really identify all your gyri, really exact position. Yeah, and if you superimpose the vessels, then you can also map it to after your craniotomy. And I always think of my colleagues, even the older ones, when I ask them after the craniotomy, so which gyrus is it? Well, they don't know. And they say, it's not so important. I know the tumor is there. But I think now we have the chance of using all this technology that's available for us, and we should try to use it. I don't know how many of all of you use 3D surface reconstruction for every case of glioma, and really think, which gyrus shall I take and to which extent shall I remove that gyrus? Yeah. So maybe we should use this technology.
I agree with you. I think that it's like being the highway and you don't have the GPS sometimes. Yeah, you know the highway, you know the anatomy, but it's always important to have an extra tool. Not because I know the anatomy, I cannot make a mistake. Yeah, so I think the GPS in the brain in some way it can help you to approach an area with more safety and security. Not dependent on that, because nothing is going to change the anatomy. Nothing is going to change our view as a surgeon. It's just to have an extra tool to try to improve our safety to the patient.
And our outcome, because we want to remove the T2 flare to a full extent. Yeah. And how often do we do surgery and then we missed some gyrus or some half gyrus because we didn't know where it was. So usually what I do, I make my plan on the 3D picture before, and I take this plan to the OR. And then afterwards, I make a personal quality management. I check did I really make it? Did I really understand where I am? Did I really remove it? You know?
Thank you.
Okay. Dr. Guzman, please, go ahead.
Hello, everybody. Great lecture. I really congratulate everybody to this meeting. Is amazing. I just want to say something personal. I have a brain lab. I think it's an amazing tool for me to plan the surgery. I mean, I do 3D like Dr. Stefan said. I do 3D. I do the tractography. I brush the tumor. I do the trajectories, and I plan everything before surgery. But to be honest, when I am with the patient, it's like the planning was on my head, what I did in navigation, but inside is for me only anatomy and neuromonitorization. I mean, I do direct stimulation of the track, and it's amazing how reliable it is. Gabriel said a question before about optic tracks. I do awake patient, and for me, it's amazing how reliable you can see the quadrant anopsia and the hemianopsia when you stimulate the patient in the track and in the radiation, and you see the arrest of the visual field. So you have to like mix every technology, and it's amazing how do you manage, like the professor said, you have to do a lot of technology, but to be honest, inside the patient is best anatomy and monitorization. I don't know.
Yeah, definitely.
Okay. Thank you. Just to say that Professor Dufault just start the lecture. If somebody want to migrate to there or stay here to one or two questions, you can finish the panel. Go ahead.
What is the
Dr.
link of
Vargas,
that?
Dr. Gabriel, Dr. Pablo.
What is the link of that?
It's in the chat.
Of that session, Professor Borba, the link. Could you write on
the chat?
Okay.
Okay. It's in the chat here. No.
All right. So shall we move?
You have more questions?
Just to comment what Francisco.
One more comment or question? Dr. Valero likes to talk about a lot. Okay, go ahead. But
just to
not too much.
Francisco said, when Francisco said, as a long time ago, it's a paper published by Mitch Berger that said that the best way to use this is the combination of navigation and mapping. Yeah. So in that way, you can certainly assure that you have both tools to work in. But I mean, navigation, mapping by itself, it's hard to identify the tumoral border, and navigation helps you to identify the tumoral border. But the combination of both are necessarily and essential for any surgical procedure, at least in
right.
Yeah.
Okay.
Agree.
You have more
Good.
comment? Juan, wanna talk? Okay. I'd like to thank everybody, all the people from Mexican Society, from Argentina Society, and more than 700 people that stay online. Same time, we have registered for this seminar 1,820, and the rotative number, you know, just when finishing the seminar. Thank you, everybody. See you next Saturday. The anatomy of the ventricles and surgery around the ventricles. Thank you very much.
Thank you.
Let's go to the
Thank you.
Argentina now.
Thank you all.
Okay.
Bye bye.
Gracias, gracias.
Bye bye. Thank
Bye-bye.
you.
Os argentinos vão me matar. Ok?
Borba,
Gracias. Tchau.
Borba, tá me ouvindo?
Outro cole. Outro
Olha,
cole. Sim, sim.
Tem jeito de tirar esses comentários da frente da imagem? Jogar no canto da tela? Porque o pessoal fica comentando no meio e coloca a tela.
Isso aí. Isso eu explico para o senhor depois. Tá? Eu explico depois privado para o senhor. Nós temos 400 pessoas ouvindo aqui. Tá bom? Um grande abraço. Eu ligo para o senhor daqui a pouquinho.
Valeu todo
Tá
mundo.
bom?
Hasta luego, gracias. Gracias.
O Paulo Cato está falando demais, já cortei o microfone dele aqui.